Thank you very much. My pleasure to be here. Didn't realize I'd be talking first, but here we go. So my job today is to go over a discussion regarding the interventional cardiology approach to cardiogenic shock. So I've called this the technical tips and tricks for the sickest of the sick. I come from Toronto General Hospital and work in the coronary intensive care unit as well as in the cath lab. No disclosures. So I think an important list to go through, and this is what the talk is going to really be centering around, are what the major decisions are that interventionalists have to face when they're faced with cardiogenic shock. And the first and very important question is whether to cath the patient at all, because as you will see, that can actually be a hazard at times, depending on what we think the diagnosis is. We have to discuss optimal access for patients, whether we're going to go radial versus femoral. And then, of course, the approach to revascularization, discussing PCI versus bypass, and Johan will go into more details about the cabbage aspect, obviously. When we're actually doing PCI, we have to talk about whether we're going to fix the culprit only or perform multivessel PCI, which is a hot topic. And then finally, there are support options and tools that are essential to think about utilizing to improve your success, including pressors, inotropes, PA catheters, balloon pump, and Impella. I'm not going to speak about ECLS. So it's, as everyone in the room knows, there are many, many causes of cardiogenic shock, and many of them are not ischemic in nature. And too often we sort of get channeled into thinking that the most common cause is an acute MI, and that if the patient's in shock, then that may be the diagnosis. But in certain cases, this can be a real hazard. So this is unfortunately not too uncommon scenario. I work in a transplant center where we're often accepting patients down for transplant assessment, LVAD assessment, etc. So a 22-year-old woman with fevers, chills, malaise presents to the emergency room with dyspnea, has low blood pressure, sinus tachycardia, which is the worst kind of tachycardia in my opinion, grade 4 ventricle on echo done in the emergency department, quickly intubated, pressors, and then decision is made to take them to the cath lab. And this is more of a reflex, because I don't think anyone in the room really believes that this woman has an acute MI with LAD territory occlusion or anything like that. And unfortunately, when this happens, it often delays things quite significantly. So 4 hours can go by, the patient's lactate comes to 15, and then they have a PEA arrest on their way down to the transplant center. And in this case, it would be much better to think about support before cath. I mean, cath could be something considered in the future, and occasionally we do get fooled by patients that present one way and have ischemic heart disease, but this is very unlikely to be the case in this case. So I think that's an important first point to make. Now, whether to do the femoral or radial approach was a topic that has been really discussed at great length over the last, let's say, 5 years. Myself and a colleague did a systematic review of the literature, and although most of the studies, well, they're all non-randomized observational studies, we did find that radial access was associated with less access bleeding, less major bleeding, lower 30-day mortality. And what I like about radial is that it frees up the femorals, because it doesn't mean that you're not going to be using them. It just means that your access for your intervention may be through the wrist, but you're going to be using your groins, and sometimes you need all that you can get to keep these people alive. So when to bring in surgical colleagues, our rule of thumb at our center, and I think this is similar to many centers, is when you have a case that comes in shock and you have what's called surgical anatomy, then we try to consult the surgeons regardless, even if we know that in our heart there's no way the patient's going to go to the operating room. I think it's very important, and we have a very great relationship with our surgical colleagues at our center, and so we call them. I mean, if it's 3 in the morning, they're not likely going to be standing beside us, but they'll answer the phone. But in the day, they usually come right down into the lab, come into the control room, we go through the pictures. And if it's a time-dependent process, like a STEMI, acutely, or significant comorbidities that are very obvious, like the patients in florid pulmonary edema, and they're not going to do well surgically, then obviously interventional approach is our default. But sometimes we can take the time to divert at this moment When there's a less time-dependent process, like, for example, a reperfused STEMI, where the patient had anterior ST elevation, they come in and that has actually improved. If they have obvious mechanical complications, which we could diagnose in the lab, or if they have miscellaneous diseases such as SCAD with shock, then it's very important to get that upfront approach. And we do send patients directly, obviously, to the OR from the cath lab under these conditions. Sometimes the surgeons feel a little bit pressured into it, but they get there. This is an example of a case that I want to show on this topic. 78-year-old woman, completely well, previous smoker, no other past medical history, had an anterior STEMI. This is her right coronary that looks relatively reasonable, but she has a very nasty looking left main. And if you look in this view, it looks like there's a lot of thrombus and haziness there. And some other interesting findings, there looks like there's distal embolization. There's cutoff of the LAD. You can see it in this view a little bit, or sorry, go back, there we go. No, I don't think I can go back. Anyway, the LAD cuts off. You'll see it in the next one anyway. We did an LV gram. LV is not terrible. It's a grade 2, 3, and there's anteroapical hypokinesis, which may be stunning related to the acute infarct, and there's no question that there is distal embolization, and some of that's not going to be revascularizable. But because the STs had come down and the patient completely was hemodynamically stable at that moment, we had the time to sit and discuss with the surgeon, and they agreed to actually take them to the OR. Before I go there, though, I'm going to ask what, occasionally I ask for a show of hands. How many patients would do left main PCI into the LAD? Just raise your hands up. No? One or two. How many would send straight to the OR without any further ado? How many would do manual thrombectomy and then bypass? A few more for that. And then medical therapy. I call it marination, where you bring the patient back to the CCU on heparin, sometimes 2B3A inhibitors. And of course, that's a potentially risky scenario because you don't know what's going to happen in terms of how they're going to do. So we actually were encouraged by the surgical team to try manual thrombectomy, and I did, and we didn't get anywhere. It really made no difference. In fact, I was worried that the LAD actually looked a little bit worse and that things were starting to shut down. So we very quickly changed gears, sent the patient to the OR, what happened was when they got there, they actually crashed right when they got into the room. So clearly doing something in a hurry was the right call. We managed to get them to surgery. We had that brief moment of sort of stability, but then they clearly weren't going to remain stable, and they needed emergency pump cannulation and didn't have time for a LIDA, but they did well otherwise. The next sort of discussion point that we have to be faced with is what to do in the setting of multivessel disease in STEMI. And there are many trials ongoing, as we know, looking at this topic. But it's very interesting. If you go back to the guidelines state, which I will discuss, that multivessel PCI at the time of their initial presentation is recommended in cardiogenic shock. But if you actually look at the data supporting that, it's a lot of observational studies, and it really hasn't been studied in a randomized fashion. We know that 80% of patients with STEMI and shock have multivessel disease, and a lot of these patients, or all of these patients, would really, a lot of them would be surgical candidates if they were presenting in a stable format, and we know that it increases mortality when they have this kind of disease. So this is another case, 73-year-old male, hypertension, family history, visiting his wife in hospital and had a code blue at Starbucks. And we often, we know that code blue at Starbucks often means that someone had a bad cup of coffee or it's not real, it's a vagal reaction, but this was real. The patient had, ironically, someone called 911. The ambulance came right into the front of our hospital and actually did a quicker job than their code team did. Diagnosed a STEMI straight to our cath lab. And this angio is a bit old, so it's not running very well, but you can see that there is an occluded LAD, but also severe circumflex disease. And the right coronary is no picnic either. There's a severe ostial PIV lesion and posterolateral disease. So now, who here would fix everything versus just the left system? Anyone say yes to everything at the time? So it's clear that the anterior is the culprit, and I'll tell you what I did. I fixed just the LAD and the circumflex. We had a good result. and the patient stabilized. And it's not that we didn't fix the right, but we did it in a staged fashion. So I think this is a very interesting topic. The guidelines suggest index procedure improves outcomes, doing everything. And there are some observational studies supporting that, including a few recent ones. But there's also some studies that really do not support it. In fact, the opposite, that suggest less is more. This is a study by the ALK PCI registry that was actually published in Neurointervention in 2015, showing an increase in death in patients when they had everything done at the same time versus partial staging. And this is going to be looked at. It's actually, there's a randomized study ongoing called Culprit Shock, run by Dr. Thiel, who did the Shock 2 study, looking at this issue. So should we throw out the balloon pump? I'm going to talk about support now. Should the balloon pump be thrown out? We know that the Shock 2 study showed no benefit, 30-day mortality. But I'm going to show you a case that I think illustrates how it can be helpful at times. 76-year-old male, multiple risk factors, previous bypass, has an arrest in the community, intubated, transferred for cath and out-of-hospital cardiac arrest management, cooling. They were on inotropes when they arrived. And if you look at the initial left ventriculogram, it looks severely depressed, severe MR, and part of this was no doubt stunning as a result of the arrest. This is the native right coronary, which is gone. No surprise, native left coronary is gone. And in fact, I'm not showing the root, but all of the other grafts are gone except for the LEDA. The LEDA shows that it's really perfusing everything, the right and some of the circumflex through collaterals, and it itself is diffusely diseased. This is another picture of it. So the question's here, what is the best approach? Medical management, balloon pump and medical management, or revascularization? Anyone choose revascularization? It's not obvious that there is a culprit, right? I mean, it looks like the patient arrested. We're not sure why. The LEDA is open. The LAD looks reasonable. So we inserted a balloon pump because the patient started to slip a little bit, and it actually did improve their status, whether it was coincidental or not at the time. And we found that their LV function improved, and they were extubated but then re-intubated several times because they were very, very sick, high wedge pressure. And interestingly, we soon discovered that it was the balloon pump that we couldn't wean. Whenever we weaned it, they went into flash pulmonary edema. And we actually changed it from the right leg to the left leg to the right leg. We kept going back and forth trying to preserve their vascular status over a period of weeks. And they kept taking them back to the cath lab. We had discussions about doing another thoracotomy and another graft to the LAD, but it wasn't clear that was going to help. So eventually, we figured we had nothing to lose. We brought them back to the cath lab, and I actually did FFR of the LAD, and I discovered that it was 0.6. Now, there are some issues related to the collateralization when you're doing FFR assessment, but it was very severe. And lo and behold, we actually stented the LAD in this setting. And we got a good result, and the patient incredibly improved. And we were able to get rid of the balloon pump, get them off inotropes, extubate them. And I now see this gentleman in clinic. He's this very lovely gentleman that bows every time I come in the room because he's convinced that we saved his life, which I guess we did. But it's a little embarrassing when you walk in to say hi to him. But he's doing extremely well, and that was an example of a case where the balloon pump really mattered. So I don't think it's time to throw it out yet. I've got just a few more cases. I know I'm getting close on time, but since I've got a little more time, I'm okay. Another discussion is what to do with pressors. That's what the focus of this during high-risk cases. This is another very high-risk case that we did. 85-year-old male with severe chest pain, shortness of breath at rest, had BiPAP in the emergency department over at Mount Sinai, which is across the street from our institution, came over on inotropes and vasopressor agents, and has absolutely frightening anatomy. This is the right coronary. And if you can see, we have some trouble here. The patient has ostial left main, critical distal left main, and actually a lot of proximal LAD disease you can see in different views. I took a whole number of shots because we were so horrified. And a balloon pump was placed in the lab. Actually, this was done by my colleague, put a balloon pump in. And the patient actually settled on the balloon, but was requiring inotropes and had grade 3 to 4 LV function, clearly not going to really get any better without something being done. So the plot, of course, thickens. They were persistently inotropic dependent, but the platelets were 56. The patient had a history of ITP. Some of this was related to that. Perhaps the balloon pump contributed. Creatinine was 160, and the aorta was very heavily calcified. And so based on all these comorbidities, not surprisingly, the patient was turned down for bypass. So then we had a discussion. What are we going to do with this poor gentleman? This is an 85-year-old dentist who's wide awake, completely compos mentis, previously very active, and talking to us saying, what are you guys going to do for me? So we discussed medical therapy, which was our default, PCI with the balloon pump, consider Impella, consider ECMO and PCI, and consider just PCI, balloon pump, and pressors. Tons of different combinations. My concern with Impella in this case was the low platelets, in particular, a degree of aortic stenosis as well, and the patient had severe vascular disease, so that wasn't a very appetizing thing. And luckily, as these things tend to do, the decision was made for us because the patient started to crash. Basically, inotropic requirements going up, started to get sicker, more breathless. So fairly quickly on a Sunday, we had to bring him in to the cath lab. So I tried to set myself up for as good a success as possible. Balloon pumps in place. We made sure the PA line was there, and I think it was a very critical thing to have that because we can see trouble coming with the PA line when they start to get wetter or sicker. So we were able to wire the LAD, and my strategy here was to stay simple. I used a 1.25 millimeter balloon for the distal left main, just to try to very gently pry open the left main and LAD. My inflation times were about 10 seconds or less for this case, so that I really didn't ever occlude flow for very long. And the other, I think, really important key is just before each balloon inflation, I actually had a nurse standing by to give a bolus of fennel. And what we did was we got the pressure up, and then it would sag when the balloon was inflated, and then it would come back. And we really have to watch that, because once they get to a certain level, obviously they crash and sometimes don't recover. So balloon. The only time that I was really frightened was right after the left main stent. I put that one in first. The flow was fairly poor, and we have a terrible dissection in the proximal LAD, as you can see. And at this point, if you can't get anything down, then you're really up the creek. And this was a very stressful, life-shortening case for me, but actually went extremely well in the sense that keeping it simple kind of won the day. We had good flow at the end. And I was actually just pulled away at a division meeting recently by one of the one of our echocardiographers that was actually looking after this patient. Saw him in clinic a few days ago, and his LV is now grade 1, which is really kind of amazing. And that I was surprised about. I didn't think it would ever get that good. So there was our final result. And the keys here were the use of the inotropes selectively. I call it skimming the trees with the balloon inflations and the phenylephrine. So my final case is just quickly discussing Impella. We use the Impella CP, which is a 3.5 liter per minute device. A 52-year-old woman who had a non-STEMI in the community, 3-vessel disease, inotropic dependent, not intubated as well, but in kind of low-grade shock, grade 3 to 4 LV function, turned down for surgery at 4 centers across Toronto, and you can see why based on the anatomy. This is the right coronary, which is fairly horrific, and again, really no LAD. It's occluded, feeding through collaterals, circumflex through collaterals, and just a large left main into the diagonal. So the only thing you would really do, I think, from a surgical perspective is consider bypassing that diag, but obviously very high risk with that kind of LV function, et cetera. So we had a long discussion, and we put the Impella in, as well as PA monitoring. It's a 14 French system, and when we got in there, we discovered the patient was actually a little bit volume depleted. They're trying so hard to dry them out that they over-dried them out, so we gave a bit of fluid. Took a shot to look at the peripheral vasculature, which wasn't terrible. It was big enough for us to insert our 14 French CP. And for those of you that aren't familiar with the Impella, this is a pump that goes into the ventricle across the aortic valve, sucks blood from the ventricle back up into the aorta, and helps offload the ventricle and improve cardiac output. That's it running. So we fixed the right. And then we focused on just doing a straight line PCI from the diagonal back to the left main. That was the only time when it was really scary. Whenever the flow diminished was when the patient got sick. And so if you look at her PA pressures during the case, she started at really normal PA pressures, and then during the post-dilatation of the LAD, which was the high risk point, I don't know if you can see my laser pointer, but PA went up to 45 very quickly. Blood pressure, the PA pressures went high, and the blood pressure plummeted from 133 to 69. And so I say that the patient only needed the Impella for a very short period of time, but that period of time was really critical for this case. I'm just about finished. So that's the final result. So ultimately, it did well. However, the caveat with these devices is they come with a cost. Bleeding is an issue, particularly in younger women. I've had lots of trouble with retroperitoneal hemorrhage because it's such a big device, and a couple times we've had to very emergently remove them and transfuse the patient rapidly. So in conclusion, when you're talking about intervention in cardiogenic shock, you have to decide up front what the role for cath is. I have a relatively low threshold for cathing these patients, as long as it's not going to actually inhibit their overall progress. We don't know what to do with multivessel PCI, and I still think that fixing the culprit may be the right thing to do in a lot of cases, because you just don't have the time or the dye currency to be able to fix a lot of complexity. So you want to get in and out and then maybe bring them back. I think the balloon pump still has a place. Interestingly, if you read an editorial by Theo recently in Eurointervention, he doesn't use them at all. He just completely stops. I think Impella is a great support device, but it has to be balanced against bleeding risks. And it's always important to get a surgical consultation, which is why I'd like to pass it over to my colleague. Thank you.
Thank you very much. Great start. Excellent presentation. Thank you.